For many years, we've been using CRT to try to remove mediators. But maybe the first step to think about is what we are doing with one of the major players when we are treating sepsis, which is antibiotics. And so can we apply rules of PK/PD for CRT? And obviously, if we think about CRT, we have the sickest patient staying for the long period of time into our ICU, so having the most important number of nosocomial infection, having also the most resistant microorganism. And unfortunately, we have also very little good data on PK/PD in CRT. So is this enough to say, well, we cannot do nothing to adapt antibiotics? Probably not. We should try to, with the data we have so far, trying to apply some rules. Needless to say that you can never apply the rules that have been built up over the years about intermittent hemodialysis, where you are almost overdosing your patient. So please, you need to have dedicated data for CRT, where most of the time we are underdosing. And there are some rules. I will be quickly looking over these. I will then speak about very important antibiotics that we have to adapt very carefully. Some antifungal absorption that we have been overlooking for years, and some conclusion. Okay, so 4 rules. First, molecular weight. Second, protein binding. Third, hydrophilicity versus lipophilicity. And for volume of distribution. And if we focus on molecular weight, and just most of the antibiotics we are using in the ICU, you see this is not a huge problem, because when you see the molecular weight in Daltons, and surely for CRT, even for vancomycin colistin, it's an easy job to try to get those out of the system. What about plasma protein binding? Again, the usual antibiotics we are using, and we know when it's over 80%, it's almost impossible to remove those by convection. And when it's below 60%, very easy to remove. So again, the majority of these antibiotics will be quickly and easily removed by CRT. Not a big issue, really. As you see, there is no word about colistin. I will come back to this. Now, hydrophilic antibiotics. As you know, the lowest volume of distribution. And you see most of the antibiotics are there. Beta-lactams, glycopeptide, aminoglycosides. Whereas for the lipophilic antibiotics, you see that you have here linezolid, and you will say, well, probably we don't need to adapt any time linezolid. Well, it's not such a big lipophilic antibiotics, and we know in some conditions like for CRT in burns, like CRT in special pneumonia where the diffusion is very important, and also in other conditions we need to adapt linezolid. So this is not really a very clear law regarding lipophilicity, but anyway. Now, what do we need to do? Well, if we just have in mind the molecular weight, the protein binding, hydro versus lipophilicity, you see that most of the antibiotics that we are using will be easily removed by convection, because above 50%, it's really an easy job to remove them. So the majority, even amikacin, 95% in one day, remove only by convection. So Not a big deal. Now, we know we need to make two major differences here. What we call the time-dependent antibiotics, beta-lactams, carbapenems, and so forth, and tazocin. And if you want to give under CRT 4 grams 4 times a day of tazocin, you have a huge peak, and you get it completely eliminated mostly by CRT, and the decay is very quickly. So the time in 1 day over 24 hours above the MIC, the MIC, is very, very low. Whereas if you do the same dose, but by continuous infusion, so you avoid a peak, you have a much less removal, then you will achieve much better time over the MIC in 24 hours' time. So whenever you have time-dependent antibiotics, please, whenever possible, go to continuous infusion. This is completely different, obviously, for peak or concentration-dependent antibiotics, well-known aminoglycoside, when you need to be above 8 to 10 times above the MIC, and then you need to give very high bolus of aminoglycoside to be sure to be above the MIC and killing bacteria. Now, let's review a few important antibiotics. Piperacillin tazobactam, we use quite often as the first line for ventilatory-associated pneumonia, and we know it doesn't have a good penetration in the alveolar space. So we know also it's a time-dependent antibiotic, so we need to give an infusion. And we know the removal by CRT is very effective, more than 80%. So how can we try to overcome this? Anytime you are giving antibiotics, especially time-dependent antibiotics in CRT, do never forget the loading dose. This is very important, to be immediately above the MIC to start with. And then, after, you start an infusion of 16 grams over 24 hours. So loading dose plus infusion. And with this, you will be most of the time above the MIC. This is extremely important, especially for ventilatory-associated pneumonia. And if you are still sticking on bolus dose, 4 grams 4 times a day, while several studies have shown that half of your patient will be underdose, under CRT, which is probably not a thing we want to have. That was for piperacillin tazobactam. What about vancomycin, also a time-dependent antibiotics? Again, a very poor penetration into the alveolar space. Okay. Very important. Most of the time, people are giving, 1 gram of loading dose in 1 hour, and then 2 grams in 24 hours. And waiting, we will see what is the trough. And then next day, the trough is 10, 12. Oh, my God. The day after, 15. So you need to go for a very high trough almost immediately. For doing this, you need a new scheme of loading dose, very important, set by Bermier in JAC 2013, 35 milligrams per kilo, because like any drugs in ICU, we speak in milligrams per kilo, okay? No fixed dose. And in 4 hours. By doing this, you are above the MIC, and you have a better trough, and then you're following by at least 15 milligrams in the resting 24 hours, and then according to the trough value. So a very important loading dose during CRT. As I said, the elimination of vancomycin is an easy job during CRT, 90% in 1 day. And then the question comes, is vancomycin a good drug to try to treat ventilatory-associated pneumonia? Well, we need to go for a very high trough because of the poor penetration. Trough between 25, 30 milligrams per liter, especially if we have a Staph aureus with an MIC of 1.5. And we say, well, we will get nephrotoxicity, AKI, CKD. Maybe not, because there are 3 other factors. First, if you have a cumulative dose in 1 day of 4 grams or more, please move to linezolid. Additional factor, if you're giving the dose for 7 consecutive days, also move on. If you have not those 2 factors, you can keep on with this dose. We have shown this in this paper in Annals of Intensive Care. And one last thing, a recent study has shown that for the first time, infusion of vancomycin are less nephrotoxic than boluses, okay? So we need to keep this in mind. And if you are still doing intermittent hemodialysis, the same rules. You have to increase the loading dose, 25 milligrams per kilo in 2 hours to be above the MIC. Okay, move on. Amikacin. Concentration peak dependent antibiotic, as you know better than I do. And when I'm getting some time around in the ward in the hospital, and I'm still seeing colleagues saying, well, the patient is in AKI, we don't want to increase the AKI, so we will be gentle. A small dose of 500 milligrams. Please do never do this again. This is really wasting of time because you will never get the peak above 8 times the MIC, and you will get toxicity. So you need, even with a patient with AKI, and surely on CRT, a loading dose of 25 milligrams per kilo. Forget about the 1 gram, please. And then according to therapeutic drug monitoring, the first dose is associated with survival. So keep this in mind. This is very important. Recent data for resistant bugs are really suggesting 30 to 35 milligrams per kilo, especially during CRT. And toxicity is more related to the exposure time and if it's done once daily. I give you an example. For endocarditis, we still see patients with gentamicin 3 times a day. Crazy, crazy, crazy. Why? I mean, you never achieve a peak like this. And you eat 3 times the same day the tubule. It's been shown to be very damageable for the tubule. So you need to give 1 time. For gentamicin, 10 milligrams the loading dose, and then 7 milligrams per day, okay? So very important to have in mind. Now, we have all very difficult patients, sometimes trauma patients, with very resistant microorganisms, and sometimes only 1 antibiotic left. And sometimes it's aminoglycosides that's only left. Most of the time, amikacin, sometimes gentamicin, tobramycin. In this very interesting review paper and a retrospective study from the group of Vincent, 15 patients, resistant bugs, only 1 antibiotic left. Well, they said, okay, we will start with a loading dose, 35 milligrams per kilo, very high, okay. Then according to the dosage, we have to have the peak above the MIC 8 to 10 times. So that gives, in one case here, 70 milligrams. If you go like this, everyone goes into acute kidney injury, chronic kidney disease, chronic dialysis, end of it. But they had a protocol, a nice protocol. They said, okay, after 1 hour after the peak, we start CRT, even though the patient has no AKI, just to remove so quickly as possible the remaining aminoglycoside and the amikacin, starting at 40 ml per kg per hour and then going sometime to 80 to really remove so quickly as possible the amikacin. And by doing this, they were able to have, out of 8 patients that were responding to the therapy, 5 survivors, and 4 of these 5 having a normal kidney function when leaving the hospital. So this is feasible even in those very sick patients. And in our institution, we had a lot, unfortunately, of resistant bugs only susceptible to colistin. And we have a similar study, like the study from the group of Jean-Louis Vincent. And the thing is that PK/PD for colistin is very special, because most of the antibiotics are only bound to albumin. So binding percentage of 50%, easy to remove by convection. Here is the game somewhat different, because there is this protein, alpha-1 acylglycoprotein, increasing 30-fold with infection. And by doing this, your percentage of binding is going from 50 to 95. So we cannot anymore remove by convection. Can we do something about this? Well, we had a patient with an intoxication a few years ago, 8 microgram per ml, apnea, mechanical ventilation, the clinical picture. And you see here in dot line the decay in the plasma by putting CRT with very adsorptive membrane. And we were expecting a similar curve for ultrafiltration. It doesn't appear to be this. It's an asymptotic curve. So everything was really trashing inside the kidney, the artificial kidney, the bulk probably, and then we had some elevation in the ultrafiltrate. And by calculating the error under the curve, we could make a model that showed that 85% of the colistin in that case, when it's so bound to the protein, is eliminated by adsorption, bulk adsorption. So we had also very sick patient, only with a microorganism only susceptible to colistin, and you know it's a time and a peak-dependent antibiotics. And then we were using the classical dose, 9 million loading dose, very important, 4.5 2 times a day, a lot of failures. So we said we will increase to 3 times a day because it's a time and dose dependent. But if you do this, everyone goes into AKI and chronic kidney disease. So we start also CRT as a preventive measure. And by doing this, because we use very adsorptive membrane, we could eliminate the colistin by adsorption. And obviously using citrate was opening the pores to allow the bulk adsorption to carry on. We had also, out of 25 patients, 7 survivors, and most of them leaving the hospital with a normal kidney function. So something to have in mind. Now, very quickly, we could also build some table to try to highlight the most important things that I told you already. Now, we know also that amikacin and other aminoglycosides are not only eliminated by convection, but by adsorption, as you can see here with natilmycin. Probably 500 milligrams per day adsorbed by the membrane, especially the new highly adsorptive membrane, on top of convection. So we might very quickly trying to go for higher loading dose. Now, last slide about fluconazole. It's a peak-dependent antifungal. And so if you give the classical dose, 800 milligrams loading dose, 400 milligrams per day, everyone is underdose because fluconazole goes into the kidney, is reabsorbed by the proximal tubule, 85%. If you have a CRT, everything goes into your ultrafiltration. So you have to give 600 milligrams BD to be above the MIC. But keep an eye on liver, QT interval, and brain. Okay. So ECMO is another issue. I skip this. Conclusion. General rules of drug dosing during CRT cannot be derived from intermittent hemodialysis table, Bennett table, just throw away. Most of the classical antimicrobials are easily removed by CRT, as I show you. For time-dependent antibiotics, use infusion whenever possible, and do never forget the loading dose. For peak-dependent antibiotics, I show you that a very high loading dose, initial dose, is very important, above 8 times the MIC. And I'm sure your nurse will say, it's the first time we are giving 3.4 3.5 gram of amikacin in the unit. Yes, but things are evolving, you know. So resistant bugs, you can use higher dose, start CRT as a prophylactic measure, like for aminoside, colistin can be also for voriconazole, etc. Knowledge of MIC is very important. Try always to get it. And therapeutic drug monitoring as a point of care of resource is really needed at the bedside. And do never forget also, in the future, the PKPD adsorption that's going to be more and more known, not only for aminoglycoside, but for vancomycin, quinolone, etc. Thank you so much for your kind attention.